So our next session is carrying on the scalp and hair theme, and I'm delighted to introduce Dr. Sharon Belmo, who's giving us a talk on Afro-Textured hair, Seborrheic dermatitis, and styling, a guide to scalp health. Now, Sharon is a consultant dermatologist, and she's also the founder of Sharon Belmo Dermatology, which is one of the first, or in fact, the first private dermatology clinic, which really helps to address issues around skin of colour and different types of hair as well. And she also works with some of the scarring alopecia foundations. So thank you very much for your talk, Sharon.
Thank you. Thank you so much for inviting me. I'm so happy to talk about my favorite subject, Afro-Textured hair. Okay, so let me go back. The chemical composition of hair types is very similar, but there are biological and structural differences in Afro-Textured hair that I'm just going to run through first before I get into the talk. So first, if you look at the cross-sectional appearance of all hair types, in African hair, you will see that it is highly elliptical in comparison to the round cross-sectional appearance of Asian hair and the intermediate or oval cross-sectional appearance of Caucasian hair. The Afro-Textured hair follicle is asymmetrical. It's S-shaped in comparison to the straight hair follicle in straighter hair types. The twisted fibers of or hair strands in Afro-Textured hair resemble a twisted rod with multi-directional twists along the hair shaft. The hair is very dry. Regardless of the sebum level at the scalp, which can be normal or higher or reduced, it's very difficult for the sebum to track down the curly hair. So we find that the hair is very dry. It's also very fragile. So the break stress and break elongation are measures of how easy it is to break something. Break stress and break elongation of African American hair is less than that of Caucasian hair, and the break stress of wet African American hair is less than that of dry African American hair, which means Afro-Textured hair breaks more readily than Caucasian hair, and it breaks easier when it is wet. It's more fragile when it is wet. It's felt that this weakness might be, is proposed, due to the points of geometric weakness that you have along the hair shaft because it's so curly. And it's felt that relatively low levels of manipulation, so just from simple grooming or hairstyling, can cause friction at these weak points, which can result in damage to the hair shaft. Just to add to the complexity of this hair type, it's associated with multiple knots, complex knots, so 2 or 3 hair strands all tangled together, or single strand knots. And these cause structural damage to the hair, which results in splitting and fraying of the hair shaft. So we have a hair type that's fragile, it's dry, which means it breaks easier, which leads to poor length retention. It's very high maintenance, I know. So let's now talk about Afro hair styling and culture. This is a whole another talk, which I'm not going to get into, but I just want to say that you cannot ignore Black history when you talk about Afro-Textured hair and styling, and the importance that Black history has in the Black community is very, very, very important to this group of people. Dating back to pre-slavery in Africa, during slavery, the civil rights movement, where the hair became a sign of pride and resilience, moving on to the 1970s when Black hair became less political, thank goodness, and more about style and just care for this fragile hair. So there are many, many hair types, hairstyles, and it's always changing. You're not expected to know all of the hairstyles. But really, the hairstyling is a combination of fashion, trends, and just being able to manage a hair type that is inherently very fragile. So we're not hairstylists, but you are going to come across Black patients with multiple hairstyles And I think it's really important to know some of them because it's going to impact how you treat them. So I'm going to go through 3 profiles I've created of patients that you're going to see and the hair types that the hairstyles that they have. So the first is natural. So not like my natural curly hair, how it grows from the scalp, free of any chemicals. These patients, and just to say, there are various curl types in Afro-textured hair. You know, some are very loose and wavy, some are tightly coiled. So there's a huge variation. And within one head, there's a huge variation in curl types as well. So just to be aware. But this profile, so these patients tend to wash their hair, say, every 7 to 14 days, which is actually standard. This is normal. This is what we want. I'll come back to that later. The wash day is often considered as self-care. They really like to take care of their hair, you know, make a whole day of it, and it's considered, you know, caring for oneself. They tend to style their own hair. There are many people that only style their hair at the hairdressers. They do it themselves. They tend to air dry. You know, they're really interested in hair health, scalp health, so they try and avoid heat. They do, however, use multiple, this is a huge generalization, but I know it. They do tend to use multiple hair products, oils on the hair, on the scalp, to try and combat the dryness and the fragility and to reduce the breakage. But given that, saying that, it means they are more likely to comply with your treatment because they are used to putting things in their hair, in their scalp, and they really want to improve their hair and scalp. So the vehicle of choice when you're prescribing treatments usually is less of an issue. And then we have patients that wear their hair straight. So it could be heat straightened or chemically straightened with relaxers, which are not used so much now. I'm not going to talk about them. Just a brief summary of hair chemistry. So keratin in human hair is made of 2 polypeptide chains held and stabilized by peptides, ionic bonds, disulfide bonds, hydrogen bonds. The hydrogen bonds are highly, highly abundant, but they're very, very weak. They will break easily with contact with water and heat. This is the process by which hair is heat styled. It doesn't last forever. When the hair is in contact with water, it will revert back to its curly or its original state, which in this case is curly. So heat styling is it's becoming more and more popular. Again, it's called silk press. So it's usually using just hair straighteners. So these patients don't like water. They don't like their hair to get wet. So they avoid water-based products, which has to be remembered when you're prescribing scalp applications. They don't want their hair to get wet. It will revert. They wash their hair less often because they want to keep their silk pressed. So it's not uncommon for them to wash their hair every 4 weeks. And they tend not to style their own hair. They tend to do it every month or every 3 weeks or whatever at the hair salon. And so products or things that you may suggest to them may actually have to go to their hairstylist because it's them that are applying them to the scalp. So that's people that wear their hair straight. Then we have patients that wear extensions. There's so many. Braids here, or twists, or weave. This is weave. So weave is when hair is attached to the person's own scalp, which is usually braided, where the hair is usually braided really flat, and the hair is either sewn on or sometimes glued on, mainly sewn on. This is controversially called protective styling. I'll come back to why it's not protective, but you may hear this term, protective styling. These patients wash their hair, most of them, less frequently because these styles take a long time to do. I've sat for hours to have my hair braided. They take a long time, and it's expensive, even more now. It's very expensive. So they want the styles to last for as long as possible. So they don't want to spoil it. So they wash their hair less often. It can be, I've seen beyond 3 months, actually. They can suffer from irritation from the extensions. You know, a lot of the extensions are not human hair. It's plastic, it's dyes, chemicals. I see, you know, irritant dermatitis from the extensions. The vehicle of choice when you're prescribing is less of an issue because their hair is underneath, so you know they're not so bothered about it changing. But they tend to have more buildup because they're washing their hair less frequently. The other things that you have to be aware of, or some of them, are cultural practices or misconceptions. Because you want to know what's being done at home. Are they doing things that are promoting seborrheic dermatitis? You know, and they may think that you know because they're so common, and they may not volunteer. But it's really important to note some of them. So one of the things, this is an old cultural habit. I'm sure my mom did it to me as a kid, greasing the scalp. And this is where a pomade or an oil or, you know, some moisturizer is applied to the partings of the hair. Avoiding water, I've mentioned, usually to try and maintain the hairstyle that they have. Lower washing frequency, I've mentioned. Applying all sorts of oils to the, not just to the hair, but to the scalp as well. It's the scalp that I have the issue with, to be honest. Castor oil, avocado oil, olive oil, jojoba oil, all the oils mixed together. They make concoctions of them at home and feel that it makes the hair grow. Castor oil was a big one some years ago. It's very thick. The big one now is botana oil. It's everywhere. It's very annoying on TikTok and all the social media. Botana oil is like treating alopecia areata and everything. So that's the thing at the moment. But yeah, applying things at home and then protective styles make the hair grow. So there is, I don't want to say truth, but if the hair is protected, so say it's in a weave or braids or something, and it's not being manipulated for weeks. As I mentioned at the beginning, the hair is very fragile and prone to breakage. So if you don't manipulate the hair that is prone to damage from just simple grooming, yes, it will break less, and then you will retain length, which gives an overall impression of the hair growing. So this is where this comes from. However, many people do these protective styles and just leave the hair. They don't moisturize it, they don't wash it, it's just left for weeks. And then they take the hair out and it's dry, it's brittle, it's dirty, and there's no protection whatsoever. So there's a myth of protective styling. And then co-washing is done less now, but this is washing the hair with a conditioner rather than a shampoo, again to combat dryness. I have an issue with it because it causes buildup on the scalp. Rinse-out conditioners are not meant to be left on the scalp. Okay, so seborrheic dermatitis in Afro-Textured hair, this is US data. Incidences, I suspect it's more, but this paper stated 6.5%. Definitely, without a doubt, a top 5 presentation in blacks in clinics. My clinic is predominantly black people or people of color, and I see it all day, every day. Just remember there are varied presentations in darker skin tones, so we often see this hypo or hyperpigmentation. You can see these petal-shaped hypopigmented macules on the hairline or the forehead. And remember that there are often coexisting hair and scalp conditions. I rarely believe that there is just sebderm. I'm always looking for something else, because in my patients there usually is something else. So just remember that. Here are a few pictures of the nice sebderm that I see every day. So, and some of them are very inflamed. Here's a patient who did have sebderm. So she presented with scaling and itching of her hairline. So where is it? So she does have some seborrheic dermatitis of her hairline. She has this hyperpigmented dermatitis of her hairline. It's common in blacks. When I examined, I always examine in full, even though she had braids, which makes it difficult. But if you look closely, She has these smooth areas that are suggestive of scarring dermatoscopically. She does have scarring. She has perifollicular scaling, perifollicular erythema, peripilar gray-white halos, which we see in CCCA. So she has seborrheic dermatitis and CCCA, and she probably, where is it? She probably has traction alopecia as well. I was going to show you a sign for traction. So that's 3 things in one patient. This is very common. This patient complained of itching and flaking. I thought she was just going to have seb derm. But when I looked, she had very dense hair. But if you look closely, she has these skip areas. She had a few of them. Dermatoscopically, she has good going scarring and perifollicular scaling, so she has LPP. So don't always assume it's seb derm. I don't know if this will play. It's one of my patients talking about her. No, it wouldn't. No. Okay, she's just talking about her scalp. All right, the usual seb derm consultation in the non-Black patient, so what I was doing when I was in NHS. Usually the history and examination is quick. It's usually a single diagnosis. Hair washing frequency, and those with straighter hair types, is usually every 2 to 3 days, minimal products, give some ketoconazole shampoo, maybe some Venovate, and it goes easy. In a Black patient, the history is never quick. If you'd heard the video before, you see they talk and talk and talk. The history is never quick. Examination is not so simple. One, if they come with braids or weaves or hairstyles, you really have to look in between to spot signs of other disorders. So history and examination are not quick. I have 45-minute consults for my new hair patients. But I can do that in my clinic, but I know it's not possible everywhere. It's not usually a single diagnosis in my experience. We know now, hair washing frequency is definitely not every 2 to 3 days, and there are lots of products. So if you see a Black patient and tell them to use a ketoconazole shampoo every 2 to 3 days, they're going to be very unhappy and probably not do it. If you give them Benovate scalp application, potentially they'll use it. Depends on their hair. If their hair's straight, they're not going to be happy. And you end up with faces like this. They're usually not happy. And they complain. And I hear it, because then they'll come and say, they didn't examine me. They didn't touch my hair. They don't know Black hair. They gave me this shampoo and it made my hair dry and now it's breaking. Blah, blah, blah. So I hear it all the time. So they're very unhappy if you don't, examine them properly or have some knowledge of their hair type and hairstyling. And this is all due to a lack of experience with Afro-Textures hair. We know it. It's not everyone's fault. There are gaps in cross-cultural understanding and training. We didn't have talks like this when I was training. Now it's changing, thank goodness. But we live in a diverse country, not just London. I grew up in Scotland. It's diverse now, so it doesn't matter where you live in the UK. If you're treating diverse populations, you're going to have to know some things, because we don't want this. We don't. Okay, so how I treat seborrheic dermatitis, these are just some of the things I do. So first of all, and I know not everyone can have 45 minutes for the first consult, but the medical history is different. It has to include a hairstyling history. Yes, we're not hairstylists, but it has to. It's very relevant to these patients. You need to know how they wear their hair. Is it natural? Is it straight? Is it in braids? How long do they wear it for? How often do you wash your hair? the sweet spot for Afro-Textured hair is every 7 to 10 days, which may seem, really infrequent to you, but like I mentioned at the beginning, the hair is dry, it's not greasy. The hair is fragile, it's more fragile when it's wet, it will break. So it doesn't need to be washed every day, and it's not practical either. So how often do you wash your hair? If they are washing their hair every 3 months, when they take their braids out, and they've come to you with, pictures that I've shown with horrible seborrheic dermatitis, you're gonna have to have a conversation. But your conversation will go better if they hear that you understand the hair type, so you know why you're saying it, and you're not just blaming them, So it does help. Who does your hair? Because some of them just don't do their own hair, and they don't know how to do their own hair, and it's their stylist that needs to have the anti-dandruff shampoo to apply before they wash. What products do you use? Because you want to know if they're using all this botana oils or any oils. Oil is just pro-yeast, so you want to know what they're putting on the scalp, and you want to advise them not to put anything unless you tell them on their scalp. Scalp just needs to be clean, clean, clean. Okay, then cultural competence, like I mentioned, is important to have some knowledge of the hair type and hairstyling. It will help. It'll help build a rapport with the patient. Tailor the treatment to washing frequency, severity, hairstyle. Examine closely, look for other conditions, because there's often, always, an underlying condition. I see CCCA all day, every day. Quite often with seb derm, if it's that bad, I'll see them and see them back 6 weeks later, because the scalp is then clean or cleaner, and I see the underlying scarring and go on and treat their LPP or whatever. So look for other disorders. It's not uncommon for my patients to have 3, even 4 conditions. All this fungal acne everyone's talking about, just always remember to look at the scalp as well. I treat really aggressively, especially maybe because a lot of my patients have underlying conditions, but I do find when they have these inflammatory scarring alopecias and seb derm, the flare of the seb derm can make the underlying condition worse, so I treat aggressively. And anti-dandruff shampoo for us is once a week, because for women anyway, men could probably do, if it's really bad, 2-3 times a week for about a month, but once a week is fine. I often layer anti-dandruff shampoos or I alternate them, I often use oral, especially if I know they're not going to be able to do it. Use keratolytic agents as well. And then, consider what vehicle you're going to use, which is based on how they wear their hair. And just ask them. They're not going to know that betamethasone comes in ointment, cream. They won't know any of this. So ask them, do you prefer a liquid or do you prefer an ointment? And it will help. Again, it will help with the consultation. It'll help with compliance. Hair care, advice, education. I mean, you think I'm a hairdresser in the clinic sometimes because a lot of it, half of the consult is that, but it's important. So some of the things that I talk about is, some of these seem basic, but they may not know. Shampoo is really for the scalp. And I ask them to avoid the conditioners on their hair or on their scalp, and use all the conditioners and all the moisturizers and everything they're trying to use to keep their hair hydrated and prevent breakage. Just keep it on the hair and avoid the scalp. Hair washing every week, 10 days max. For seb derm, I say 7 days. One thing I sometimes say to them, because the shampoo I like the most for anti-dandruff, as an anti-dandruff in black hair is Dercos. But if they are using other ones that are more drying, I say you can coat your hair with conditioner first and then apply the shampoo to the scalp. So there's a barrier between the hair and the shampoo. I tell them to buy, on Amazon, a bottle with an applicator so that it goes directly on the scalp. I also tell them to ignore the fact that it says shampoo on the bottle, is scalp treatment. The Sebderm is not in the hair, it's the scalp. So I emphasize that this is a scalp treatment. I think that helps. And yeah, protective styling advice, I have to explain that if you're gonna put your hair in certain styles, you do have to protect it. You have to look after it as well. And then I recommend hairstylists and hair care brands and all sorts. There's a long consult, but I hope this helps. Thank you.
Thank you so much, Sharon. This was a talk I definitely needed. 20 years ago at Guy's and St. Thomas's, where I reckon as a registrar I had a few faces like that. So, but absolutely brilliant. And I think it's so important to actually understand, how different people approach it. And I think you're right. If you need to give specific instructions, but if you come across like you've got absolutely no idea, they're not going to listen to a word you say. So that was super helpful. Now, we've got quite a few questions. Some of them are for Mike and Simon's talk, and we'll be addressing those before lunch. But we're going to take the questions, if that's okay with you, Sharon and Kavar. Sharon, I've got a question for you about one of your dermoscopic images, actually. Yeah. So if we can just go to that. So somebody's asked, from the dermoscopy images, please explain why there is scarring in between the hair follicles. I can't see the signs of scarring. So if we could just go back and have a look at the image, that would be amazing. While you're finding that, Kavar, I'm going to come to you with some of the questions. So we've got for children, which dose, and is there any monitoring that's needed for terbinafine?
So for terbinafine, it's all weight dependent and it's all on the BNF. So the dosing, there's 3 different dosing for the pediatric adolescent population. If someone doesn't have any background of any liver disorder, then for 4 weeks, I don't do any monitoring. But if there's anything more than 4 weeks, then I would check LFTs. I'd also just be careful if there's any background of connective tissue disorders or psoriasis, as sometimes terbinafine can flare that.
Thank you. Okay. Sharon, are you happy to discuss the image?
2 of them had scarring. This is scarring. Scarring is loss of the follicular ostia. So there's nothing there. It's smooth. I wish I could zoom, but you see these just smooth patches with nothing, no hair, no hole, no nothing. It's gone. The follicle has been wiped, it's fibrosed. So scarring just some patients actually, when I say scarring, they think that they have scars on there, and they say, I don't have any lines, I don't have any scars, but I just say it becomes smooth. That's the best way I can explain it. So there and there's nothing there. It's common to see white dots and black scalp. That's normal, but it becomes irregular and scarring. So.
Fantastic. Thank you. So a question for both of you. Would you use oral itraconazole for sebderm without lab-positive culture?
I use it all the time.
Yeah, if it's severe enough, then yes. But I'd also, like my colleague said, I'd also be looking to make sure there's nothing else going on except for sebderm.
Perfect. If ketoconazole does not work for sebderm, we may have just answered this, what would you recommend next? And would you give beta-cap alongside any shampoo, even if it is fungal in sebderm? Both of you. What?
So I think steroids are a double-edged sword. I think it can obviously help in sebderm as well, but if you've got a fungal infection, it can help the inflammatory component, but obviously there's a risk of immunosuppression as well. So that's why I'm so keen on the scrapings. So as long as I know, then I can just focus on treating the fungal side of things. What was the first part of the question?
So it was if ketoconazole doesn't work for sebderm, what would you
I actually I'm using a lot more Vichy Durcos, especially since the ketoconazole, there was a shortage of ketoconazole, as I just feel it's better tolerated, and the salicylic acid component can help with the keratolytic element to help remove some of that scaling as well. I think the most important thing is concordance. And if you have something that's causing irritation or dryness, then patients will not use it. So we have to find something that patients are going to use. And like my colleague said, obviously the frequency of it you have to tailor to the patient in front of you.
Perfect. This is a really good question about people who can't afford the multiple treatments that we actually prescribe. You give them 5 different things and that's going to cost them, £40, they can't afford it. So this was a question that came in for you, Sharon, that they've got a few patients with psoriasis, with thick, scaly scalps, can't afford the cream. Do you believe in using products like olive oil or anything that they can get that's slightly more cost effective?
I mean, olive oil, I don't like oils on the scalp, to be honest, but it depends what you're treating. If the aim is to, get rid of the thick scaling, sometimes olive oil, which is obviously very cheap, will help to remove or help to lift the scale. But you can then, run the risk of, developing other conditions. So I think it depends on the patient's main concern. I don't know what's available on NHS now because I'm private, but the shampoos are not so expensive. One bottle will last, a long time.
Yeah. Fantastic.